Hi, good afternoon, everyone, and welcome to today's webinar. Next slide, please. Welcome again to our webinar, New Jersey Comprehensive School-Based Mental Health Webinar Series. This is session 6, Suicide and Substance Use Risk Assessment and Prevention. Next slide, please. And on your screen, you'll see our upcoming webinar date. Our next webinar on session 7 on funding will be held on Tuesday, April 12th at the same time as today from 3 p.m. to 4:15 Eastern Standard Time. We hope you will join us. Next slide, please. And on your screen, you will also see our current offerings for our New Jersey school-based technical assistance calls. These calls are more in-depth training and consultation provided to school mental health teams and districts. Our next one is scheduled on Tuesday, March 29th, 2022 from 9 a.m. to 10 a.m. and then another one from 10 a.m. to 11 a.m. Although registration has been, we have a limit on registration, we do also have a waiting list for those sessions. So the Northeastern Caribbean Mental Health Technology Transfer Center, our goal is to enhance the capacity of the behavioral health workforce to deliver evidence-based and promising practices to individuals with mental illnesses. We also receive supplemental funding to support school teachers and staff to address student mental health, as well as support healthcare providers and wellness and self-care activities by a provider's wellness grant. Next slide, please. And if you're interested in staying up to date with the events that the Northeastern Caribbean Mental Health Technology Transfer Center is offering, we ask that you please sign up to receive our email newsletters and our email campaigns announcing our future training events. And you can do so by clicking on the bit.ly link that you see on the screen. And this link is also shared in our chat box. Next slide. Following our webinar, we will ask you to, if you could please complete a brief survey. We value this feedback and use it to improve our activities and inform our future activities. These surveys are also important because our continued funding is linked to them. So we thank you in advance for your feedback. Next slide, please. We also want to let you know that this webinar is being recorded and will be posted to our website along with the PowerPoint presentation within a week of today. This presentation was prepared for the Northeastern Caribbean Mental Health Technology Transfer Center under a cooperative agreement from the Substance Use and Mental Health Services Administration, or SAMHSA. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. We ask that you please not reproduce or distribute this presentation for a fee without specific written authorization from the Northeastern Caribbean Mental Health Technology Transfer Center. This presentation will be again recorded and posted on our website. At the time of this presentation, Marian Delphin-Brittman served as Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. Next slide, please. We encourage you to interact with our presenters during the webinar by using our chat feature. We ask that you please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time toward the end of the presentation. During the webinar, our presenter may pose questions to you, so we please ask you to use the chat feature or the Q&A pod to submit your questions. Now let's begin our webinar. We have with us today Dr. Alicia Lukachko, Superintendent Beth Norsha, and Ms. Maureen Brogan. Dr. Alicia Lukachko works with the Northeastern Caribbean Mental Health Technology Transfer Center as a Senior Training and Consultation Specialist in School Mental Health. She is a faculty member at Rutgers University Behavioral Health Care and the Robert Wood Johnson Medical School, Department of Psychiatry. Dr. Lukachko has a dual background in social work and public health, specializing in psychiatric epidemiology. She is a licensed therapist, a certified school social worker, and has extensive experience in program design, implementation, and evaluation. In addition to her current work in the areas of school-based mental health and peer support, Dr. Lukashko's research interests have spanned the roles of culture, discrimination, and trauma on health and utilization of mental health services. Superintendent Beth Norsha is the superintendent of schools in the Maple Shade School District in Burlington County, New Jersey. She has been superintendent for 8 years and has been in education for 25 years, all of them in Maple Shade, where she started as a second grade teacher. She has taught or has been an administrator in all 4 buildings in the district. Superintendent Norsha prides herself in working as part of a team and empowering others. Maple Shade's district equity team has also been asked to discuss their journey at Reese's Equity Leadership Network in the past. She lives in Marlton, New Jersey, with her husband and 2 daughters. Ms. Maureen Brogan is the program manager for the statewide Traumatic Loss Coalition. The Traumatic Loss Coalition for Youth Program, or TLC, at Rutgers University Behavioral Healthcare is New Jersey's primary youth suicide prevention program funded by the Department of Children and Families. The TLC is an interactive statewide network that offers collaboration and support to those working with school-aged youth. The dual mission of the TLC is excellence in suicide prevention and trauma response assistance to youth serving organizations following unfortunate losses due to suicide, homicide, accident, and illness. Ms. Brogan is a licensed professional counselor, approved clinical supervisor, and a diplomat at the American Academy of Experts in Trauma. She is a master trainer in evidence-based practice of suicide prevention, question, persuade, and refer, known as QPR. She is certified Talk Save Lives trainer for the American Foundation of Suicide Prevention and the assistant producer of Signs Matter, early detection online suicide prevention training for educators. She is a certified psychological first aid trainer for the National Traumatic Stress Network. So I will turn it over to our presenters, and again, welcome everyone.
So good afternoon, everyone. The first part of our presentation starts off with suicide risk assessment. And this is really an overview. And I also want to start off by saying, thank you. Thank you for joining us today. These are difficult topics to kind of get our brains wrapped around. So I want to acknowledge your bravery, your willingness to open your minds to say, hey, this is important. This is affecting our kids in our classrooms, in our homes. So I just want to say thank you so much for taking time on your Thursday afternoon to join us. So we're going to move ahead and jump into some of the suicide prevention stuff. So probably don't have to tell this audience, like, obviously there's a need, but if you read the newspaper, and it was like front page on the Star Ledger at one point, was the increase in emergency department or the emergency room visits during the pandemic. And there was even some data that said when they took a month time in 2019 and compared it to that time during 2021, there was an increase of 51% of females visiting our emergency departments. Some with suicidal ideation, others with anxiety, possible depression, and really being at home. Many schools still hybrid or not in person also stem to be like, parents were saying, what do I do? And another shout out to our schools. I think what the pandemic taught us is that we rely on our schools a lot to be the eyes and the ears of protecting our kids. And when we don't have those systems in place, we use the emergency room because parents are afraid, guardians don't know what to do. So we know that I sit on the Child Fatality Review Board. So I have to say, we review every single death by suicide in the state of New Jersey. And we're talking about numbers increasing slightly, but they're more than numbers. These are kids, these are our students, these are our family members. So when you even hear that there's been even an increase of 1 or 2, you think about that's 1 or 2 lives. When you hear that, oh my gosh, there was a 51% increase of young females visiting the emergency room because of some type of suicidal ideation or anxiety or other mental health issues that we didn't know how to handle. And not so much for our males. However, what we say about our males is, I don't think it's really necessarily that they didn't have as much of an increase in some of the feelings they were having or some of the stressors they might have been feeling. It's they don't tend to frequently verbalize it as much. So then we don't bring them to necessarily the emergency departments. So that 4% increase for them, I wouldn't be surprised if that was actually a little bit higher. And what we know in the field of suicidology is that it's still the second leading cause of death for our 10 and 19-year-olds. There was a time when I studied the data, 10-year-olds weren't even on the chart. We didn't have enough data. And we used to say like 12 to 19. Now we're even starting to see data that's significant enough to put 8-year-olds. And yes, unfortunately, here in New Jersey, we've had deaths by suicide of 8-year-olds. So that's just to give you an idea of like, hey, why are we even doing this risk assessment? Why are we having this conversation? This is why we're still losing our kids. So we're going to move on to the next slide. And then when we're talking about risk factors, there's a whole bunch of risk factors, and they can be your health, environmental, historical. What we do know in the field is that we want to pay attention to risk factors. Risk factors don't by any means mean cause and effect, because you could have a whole bunch of risk factors. And we've seen some really resilient kids that had tons of risk factors and never had suicidal ideations. Then we've seen others that had only a few risk factors, but had chronic suicidal ideations. But these are things we want to pay attention to. It's something to look out for. So, if there's an underlying mental health condition, substance use, and that's why I'm so glad we're talking about substance use and abuse next and screening for that, because they go hand in hand. You see anxiety, you see some depression. But I will also say about the mental health component, there was a time when the data and the American Foundation for Suicide Prevention would say 90% of people who die by suicide have an underlying mental health disorder. They're now saying it's not necessarily 90%. That number has gone down quite a bit. So we can't just say it's only a mental health issue. It's also these other environmental, historical. Has there been exposure historical to a suicide? That makes you more at risk. Have you had prior attempts? That puts our young people at a higher risk of attempting again. Has there been, with their ACE score, adverse childhood experiences, has there been abuse or neglect, putting someone at higher risk? And also too, environmental. We want to make sure, like we're always talking about access to means, is that can they get their hands on the gun? Can they get themselves stockpiling medications in order to have the means to actually do something so harmful that it results in death? So these are also too, like, are there chronic life events and stressors that are going on for people? So with the warning signs, things to look for, not cause and effect, but things we want to pay attention to, but also too, if you're concerned about a kid and they don't have a lot of risk factors, it's always worth looking into and asking some more questions of like, tell me more, and trying to like peel back the onion. And that's what I say suicide is. It's an extremely complex issue, tons of layers, not one cause and effect, but you usually see more than one warning signs. And that's what we've learned from the Child Fatality Review Board. When we look back, we look at it not to blame anyone by any means, but to say, what did we miss? And what did we miss as systems? What did we miss at the home? What did we miss in the school? What did we miss at on the soccer field? What did we miss in our faith-based? Or what did we miss in our pediatricians? So we're all in this together. So these are just some of the risk factors. And also too, you have access to the guidebook, which has all of this and so much more. So I encourage people to like go back and review some of that. So then we're also going to move on to look at, after we have identified some risk factors, we also want to look at what are some protective factors. And what I like to say is, summarizing it, is connection is protection. So if you have connections, and these connections are like family, peers, community support, but also too, connection to your healthcare, connection to mental health providers. And then you also have an ability through those connections to practice and develop problem solving and coping skills. These are all protective factors. These are all things that are going to help someone maybe not get to that point where if they are having suicidal ideations, they actually want to act on it. You hear it all the time, the social emotional learning, SEL. What a great protective way of setting up for our young people to learn different skills. So hopefully they can self-regulate and manage what might become overwhelming. And also another extremely important protective factor is if you can limit the access to lethal means. So if you have a gun in the home, is it locked up? Is it double locked? Is it out of the way where someone you're concerned about really doesn't have access to it? In the field too, we say, if you're worried about someone, get it out of the house completely. In New Jersey, we do know it's a little bit difficult we can't shut down bridges and we can't shut down train stations. So we always know there's going to be certain areas that we can't completely shut off and push away, but we can put signage. We can make it more difficult. We can have it not so easy to access those for walkways on bridges and things like that. So we're even looking at how do we increase those protective factors. And also too, we know from doing some of our studies that right now, one of the methods, the means that people use to take their own lives, our young people happens to be suffocation, which is they're hanging themselves. So that's a really difficult one to kind of limit their access to means. So even if we can do that, we still need to do more than just limit access to the lethal means. We have to be looking for other protective and risk factors and resiliency in helping our young people. And also too, I think sometimes we minimize that culture and religion can really be important protective factors. Sometimes we lose how important, either if it's faith-based or something that's a ritual that becomes a part of who you are. Because again, going back to the connectedness, if you feel connected, whether it's to a higher power, if you feel connected to your cultural history, you're connected to something. That's going to be an extremely important protective factor. So now we have our risk factors, our protective factors. We're going to move on to getting into more of the meat of what we're looking for too, is what are we looking for in with our students? And also too, that there might be more than one warning sign. But this is really, if you're hearing this, or you're hearing people in your classroom, your hallways, the other thing I also say about suicide prevention is I love when we do responses and we're working with students and we're doing trainings. I love being in the cafeteria. I love walking the hallways, because that's when we hear some more of the spontaneous conversation rather than structured conversation. And you can sometimes catch on to, are they talking about killing themselves? Is some young person saying they feel really, really hopeless? Or I don't have a purpose. I don't know why I'm here. What's the use of living? Also too, Thomas Joyner did some really great research and work about why people die by suicide. And he's saying, when you're hearing that someone feels that they are a burden to others, red flag, red alert. That is for him one of the big part of the social connectedness and feeling disconnected, or feeling that, you know what, my parents would be better off without me. My teammates would be better off without me. My girlfriend would be better off without me. Any of those things, when you sense that they're saying hey, they're kind of feeling, expressing that they may be a burden to someone, we want to pay attention to that. Or if they say I'm in constant pain and what's the use, that can be psychic pain. It can be physical pain. Sometimes in the field too, we forget to talk about the physical pain. There are some young people, whether they're suffering from lupus, eating disorders, different disorders that they have that actually create a lot of physical pain. If they're talking about a lot of physical pain, we want to make sure we're checking in on how they're managing the emotional and the mental health, mental pain that they might be experiencing. And also too, feeling trapped. And sometimes with young people, when you say, how do they feel like they're trapped? We see a lot of this in the juvenile justice system. When they feel oh my gosh, I'm going to court and they are most likely going to have me go to a juvenile detention center, and feeling there's no way out, or feeling that you've put yourself or your family in such harm, whether it's like gambling debts or an addiction, and you feel like there's just no way out. If you're hearing that kind of language, we just really want you to pay attention to these warning signs. So we're going to move to the next slide and talk a little bit about some of the behaviors. And these are just some, and I know you can all read, but if they're researching how you might end your life, and if they start to isolate and withdraw from activities that used to bring them joy, and now they don't do it anymore, sleeping too little or too much. And I think what's really important with these warning signs and these behaviors is I always say to people, what was this youth's baseline? What were they like in the world prior to like the last couple of weeks or the last couple of months? Because sleeping is really hard. You have teenagers that like sleeping till 12 or 1 might be normal for them. But if you have a kid that was always up at 9 to get to work or to go to the gym to work out or whatever, even on the weekends, and now they're sleeping till 1, then that's a difference that we want to pay attention to. Or if you had a kid that used to sleep through the night and be like, "Whoo, I love my 10 hours of sleep and this is great," and now saying I'm up every 2 hours, we want to pay attention to their sleep because there's been a change in their pattern. And that's the same thing with if they're, what's their social life like? If they were always very social and now they're withdrawing, that's something we want to pay attention to. If they were always on the quieter side, maybe a little more reserved, wasn't as social, that wouldn't become something that we're concerned about. But it could be the other extreme too. If you have a quieter child that all of a sudden is just very active and very verbal and even sometimes too agitated, and it wasn't an agitated child, you're looking for that change in behavior. This is it. I laugh at this one, giving away prized possessions. And I laugh about it because that was the training in my master's program on suicide prevention. So going back 30 years ago as a clinician, and I was working on my master's in clinical psych, that was the big thing. Pay attention, Maureen, if some youth says they want to give away their prized possessions. And I think that was the extent of our suicide prevention. So I do feel that I'm obligated to go out and train people and say, yes, that still is an important behavior warning sign that we want to pay attention to, but there's so many other things that we need to include and pay attention to. So all of these things, withdrawal, aggression, fatigue, are just some examples, again, looking at that baseline and what their difference was. So then we move on to saying, how do we say, what do we do with this? Now we know we have a problem. Now we know what we're kind of looking for. But education, this is prevention. So we want to train our faculty, our staff. We want everyone, when it comes to suicide, it's a public health issue. It is not only a mental health issue, as we know from some of the research now saying it doesn't have to be 90%, it could be 50 or 60% of people have an underlying mental health. And we also want to include as many partners as we can. And we want to encourage help-seeking behavior. So again, for all of you school folks, so appreciate the work that you do, because when you probably signed up to teach or be in the education system, you probably didn't know you were signing up for all of these other things that you're an important partner in this work. So again, thank you for the work that you do. So then we move on from what are we doing? What are some things that we can do? And there's so many more. And it's really what fits in your school, what works. It was mentioned that I'm a master trainer in QPR. One of the reasons that I really do like QPR is it can be delivered in 1 to 2 hours. When we were working with schools, we actually wanted to do assist as well. And a lot of superintendents and principals told me, like, why, we're not against assist and we know suicide's really important, but they're like, you can't have my staff for 2 full days of training. So that was one of the reasons that there's a whole bunch of different kinds of trainings, and youth mental health first aid, that was very similar too. It was an 8-hour course, different components that might fit in for different schools and different organizations. And also to who are you training? You want to figure out who you're training and to what degree, but these are all just some really great prevention trainings that you could explore a little more and maybe deliver, to your staff. So when we talk about, of course, we want to train everyone. And when we say train everyone, I also mean, like we had said, faith-based. And when we talk about training schools, I'm not talking about only the counselors. I want to train the bus drivers aren't always employees of the school, but I want to train the bus drivers, and I want to train the coaches, and I want to train the paraprofessionals, anyone that interacts with kids, we want trained. But when we talk about, like, we have thousands of kids in our district, what are we going to do? You may want to do some universal screenings. And this is because if you're doing universal screenings, it's like all the students, and then you can do a screening. Some schools do them once a year. Some do it like at the beginning, the middle, and right before the summer break. We'll do like a universal screening. So they do a screening across the board. And it really is used to help identify maybe some students who are struggling a little more, or experiencing some challenges that maybe those challenges are starting to become overwhelming. And the important thing to know about screening, and we're talking about tier 1, is this is like for everybody, is that they're not intended to be diagnostic. They are your basic like screening. A lot of them are 3 to 6 questions. So that's our like tier 1, where we're going to screen every student in our building. And then we can go on to the next. When from screening, we may identify some students that are like, I'm concerned about, I asked those 3 questions and I'm concerned about their responses. That's when you would want to move on to a further assessment. So these are like students that have been identified that might need a little more, like, tell me more. I want to dig a little deeper. And these are also can be administered whenever you have a suspicion of risk. So, and also too, I always say, it's like, don't hesitate to really ask the direct questions about their thoughts and behaviors. And back in the day, one of the biggest myths, and even too why people didn't want to call the Traumatic Loss Coalition in, was like, if you talk about it, they're all going to think about it and they're all going to want to do it. And what we really have learned, and we have the research to back it up, is like, that is such a myth. That is not true. If we don't have the conversations, we're more likely to see an increase and put more kids in danger by not having the conversation than having the conversation and identifying more students that might need some of this help. So when we're talking about assessments, and we'll move on because you can also do some further screenings as well beyond the risk assessments. So after we did, screening for everyone and then assessing, then there's going to be some where you want to do more of interventions. And these are also just 2 examples, like coping and support training, as well as reconnecting youth. So this is some interventions that might actually help when you've identified some of these kids, like, hey, they might need a little bit more. There's more, again, in the guidebook too, about what these interventions are. So we're not going to go into them due to time today. And also too, if you are concerned about a youth and you see the warning signs and you're reviewing it and they say they want to die by suicide, they can't go on any longer, they want to end their lives, they want to kill themselves, you need to act immediately. And you also at the same time need to follow your district policies and regulations. So one of the things with question, persuade, refer is you ask the question, are you thinking about killing yourself? And in some schools, they're like, well, we're not supposed to directly ask the question. We're told if we're concerned to bring them to whoever it is, it's the counselor or whomever is identified. Follow your policy and your procedure, and never leave the student alone if you're concerned about a student. Stay with them while you seek further help, while you're connecting. And we always say too, the best thing is like a warm handoff, is that you can hear them and be with them until you can get them to the next level. So, and then if you should have a student that either had to go out for screening, if they have been hospitalized and they've been out of school for a little while, we want to have things in place for their return. And also to what I always say, as well as in the world of trauma, is voice is choice. And it's very empowering when you're including me. If I'm the survivor of anything, any kind of traumatic event, including a suicide attempt, it's very important that I'm involved in my returning back to school. What's going to work for me? I want to be at the table. So it's really important to have the student voice there, but you want to include what faculty need to be informed about the return, who's going to be the support system. And we're going to have the students also help us identify, we may think certain adults would be fabulous in certain roles. We want to hear from the youth. Who do they think are those people that would be fabulous, trusted adults or to go-to people if they're starting to feel overwhelmed or that things are starting to spin a little bit out of control? We want to make sure the family feels supported too, and that we want to have an individualized reentry plan. And that's really, if you're including the youth, if you're having a meeting with them and the family, you are then making it about this child's return to school and not just like, oh, well, this is how we do it for everybody, A, B, C, D. You want to individualize, you want to collaborate, you want to get some input from any clinicians that have been working with them, and you want to develop like safety plans and things that, so they're going to be successful. And that's what's really what we want. We want them to return to school and be successful. So there's tons that you can go on off about return to school protocols as well. So we're going to keep moving on today due to time. So you want to team up. You want to make sure that you have important collaborators. You know, like no one's doing this in isolation. It's not just one person who does screening and that's all that that's the only person that does screening. We're all having our eyes and our ears open. We want collaborators, you know, from the administrative level down to the teachers that have more face-to-face time, as well as like our counseling and staff that might have more clinical skills, and of course like the parents and the students themselves. And I again emphasize how important it is with our students that they know, because a lot of times they tell each other and they leave us adults out of it because basically we know nothing, but they tell each other things. So we want to make sure that fellow students know if they're concerned about a classmate or a teammate or a best friend, what do they do with that? So they're part of our collaborative network as well. So after we're teaming up and doing some of our risk and assessment, again, it's about engagement. It's engagement that the family, the community, who are other people that can bolster the protective factors like connection, and also at the same time be extra eyes and ears for us, because parents can't be there all the time, teachers aren't going to be there all the time, counselors aren't going to be there all the time. So I like to say, how do we build the safety net? We're going to move on. And then we're also going to say we want to make sure that we're exercising like cultural humility, that we're also demonstrating and that we're respectful of different cultures and what does this mean for them, and creating plans and building on their strengths and how do we engage. And I think it all has to do again with that respect and incorporation and really just being fully present. And I like to say too, like humble, to be like when someone's sharing some really difficult stuff to talk about. And when you're talking about suicide, there's still a whole bunch of feelings of shame and guilt. There's all these emotions going around. We want to have some cultural considerations too about like, what is this like for this person in their society, and also too, or even a school has its own culture. What is the cultural feeling of this school, and how do we make sure we're sensitive and aware of that? And again, I think if we're being respectful and exercise humility, I think that we can't go wrong. I think that we really can learn a lot from the people that we're working and interacting with. So that's really about what we're going to go over today with the suicide risk assessments and prevention. And now I'm going to hand it off to Alicia to tell us a little bit more about how would we continue this with substance abuse, another important topic. So thanks, Alicia.
Thanks so much, Maureen. And so now we're going to move to having a discussion around substance use risk assessment, prevention, and intervention. And I just want to start off with a question that you can add your responses in the chat. So what substance use prevention programs are currently being conducted in your schools? And I'm curious to hear from you all. And while, just in the interest of time, while you're adding to the chat, we're going to start with some background and significance to substance use. So it's estimated that about 14% or 1 in 7 Americans will develop a substance use disorder in their lifetime. And over half of these cases, they start using substances before the age of 18, and then they develop substance use disorders by age 20. And we know that early substance use is a critical predictor of developing a substance use disorder in later life, and especially when the onset occurs before the age of 14. And for those youth who develop a substance use disorder in adolescence, there's really a significantly higher risk of persistent disorder and more severe disorders. So adolescent substance use is associated with a host of negative and other health and other life outcomes. Things like poor school performance, disengagement with school and family, and interpersonal problems with family and friends. Adolescent substance use often co-occurs with risk-taking behaviors and also with mental health challenges, including substance use disorders. And there's also a growing body of evidence that there are disruptions in cognitive functioning and also neurodevelopment associated with repeated substance use. So for example, we have some results from longitudinal studies, most of which focus on alcohol and marijuana use. And these show impacts of substance use of areas of attention, memory, visuospatial learning, processing speed, and earlier and more heavy substance use, as you can imagine, is associated with worse outcomes. Looking at some signs and symptoms of youth substance use. So we have our most immediate acute symptoms, which include impaired judgment, disinhibition, and incoherence. And then there's also lack of motivation, withdrawal from usual routines and activities, appearing frequently tired, depressed, or hostile, having changes in peer group, changes in eating or sleeping, declines in hygiene or academic performance, and also some deterioration in relationships with people that are in your life and cared for. And I want to note that these symptoms, they overlap with a lot of others for indicators of mental health needs or mental health challenges. So it's always important to look a little deeper and try to get a better sense of what's going on with students. So when looking at national trends, the Monitoring the Future study, which is a very large nationally representative study out of the University of Michigan, and it collects data on 8th, 10th, and 12th graders, among others. And this reveals that alcohol and marijuana, they remain the most widely used substances by adolescents. And here we're looking at data between 2010 and 2020. And it shows some, significant prevalence of alcohol and marijuana use among late, middle, and high schoolers. And this, exists despite some declines that we see with alcohol use, which have really leveled off. And then when looking at past year marijuana use, this remains largely steady during this time period. And interestingly, when we look at 2021 data, it shows some pretty substantial declines in most forms of drug use, which might be surprising, including vaping, which saw drastic increases over the past few years and since 2017, when the data on vaping was started to be collected. And researchers really attribute the recent drop to, in part, to changes in perceived risks and attitudes, but largely because of perceived changes or changes in perceived availability of substances. So it's understandable given the circumstances around the pandemic and less social engagement, and also spending quite a bit of more time at home with parents and other caregivers. It'll be interesting to see what occurs and whether these declines hold as social engagement increases. And I'd like to just mention a little bit about adolescent brain development and substance use, and why it's such a vulnerable period when it comes to substance use and substance use disorders. So during teenage years, parts of the brain that control emotion and reward are developing very quickly. Meanwhile, those that help with sound decision making and impulse control, those aren't developing at the same rate. So it really leads to an imbalance where there's a strong drive to maximize pleasure and minimize pain, but then a limited capacity for good judgment and decision making. Looking at risk factors for substance use, we can look at these in 3 different domains: individual, peer, and family community. Uh, Among individual risk factors, we can see poor self-regulation, poor executive functioning, externalizing problems and behavioral problems, and also challenges with academic work, school failure, with peers, things like peer rejection and isolation, peer drug use among adolescents. And then in the family and community domain, poor family functioning and conflict in families plays a big role. Inconsistent discipline and low involvement of parents and other caregivers is important. And then, as can be expected, parental substance use disorders and other mental health disorders among parents play an important role, as well as trauma and neglect in the home and community. And it's important to note that the relative significance of these risk factors, they can vary with developmental stage. So for example, for adolescents, peer factors might be more important than in younger years. And moving on to protective factors, given the risk factors, it makes sense that the protective factors, often just the flip side, include good self-regulation skills, strong executive functioning, and academic competence. In the peer area, really, building those effective interpersonal skills and positive peer relationships. And for families, having strong family functioning, consistent support of parents, and also what importantly when looking at schools, school and community engagement is associated with less risk. And keeping these risks and protective factors in mind, we're just going to talk about substance use prevention and intervention in schools. And some of the key components that have been shown in research to be associated with most effective programs. So to begin, one is a focus on protective factors and risk factors. As we've reviewed, effective programs really look to strengthen protective factors, reduce the risk factors. Most effective programs are also interactive, and they incorporate more than one component. So for example, there might be a school-based component focusing on individual risk factors, and then combined with a family component, which focuses on those. Early intervention is key, especially with attention to major school transitions, like transition from middle school to high school. And programs really should be focused on being longer term, having repeated sessions. And another important note is having boosters in later years so that knowledge and skills are reinforced. And one thing I want to emphasize is that reducing risk and enhancing the protective factors for substance use really contributes to a wide array of positive outcomes for students, supporting academic success and general well-being. And it really maps on well to a lot of other programming that's already in place in schools. So looking specifically at the elementary school level, most successful programs enhance academic success, particularly in the areas of reading, self-control, social problem solving, emotional awareness, and communication. And among middle and high schoolers, many of the same factors or elements focusing on academic supports and study skills, communication skills, healthy peer relationships, really trying to build assertiveness skills and self-efficacy, as well as work with anti-drug attitudes and refusal skills. And one other thing that's important really to note about middle and high school programming is these prevention programs should really address all forms of drug use and abuse, whether alone or in combination. And it's important to know the type of drug use that's particularly problematic in a community and be able to incorporate that in the programs. So looking at substance use prevention through the framework of the multi-tiered system of supports, we see in tier 1 or universal, the universal level, programming is geared towards all students, and it focuses mostly on primary prevention and health promotion. One of the main goals, again, is to decrease risk factors and bolster protective factors, and that's really a pillar across all levels. And one example or two I have here of evidence-based universal programs include Life Skills Training Program and Project STAR. And I just want to note, as Maureen mentioned, that we do offer a resource list included in these slides. And you can also refer to the New Jersey Comprehensive School Mental Health Guide for more information, and including additional programs, evidence-based programs. At the Tier 2 level, this is targeting students at higher risk for substance use, early substance use, and again, focusing on building the protective factors and reducing risk. And these students who could benefit from this level of support, they may be identified through those universal screeners and psychological assessments, in addition to referrals from schools, parent and students. The Strengthening Families program is an example of a Tier 2 evidence-based program. Looking at Tier 3 or indicated interventions, this supports students who've already initiated substance use and those who may show signs of early onset SUD. The primary goal at this level is to mitigate ongoing risk and really prevent symptoms from getting worse. Substance use screening tools could be used at this stage to identify students who would benefit. In addition to the referrals, individual and group counseling may be incorporated at this level, and community referrals as needed are a key component. And one example of a program that's at the Tier 3 level is Project Towards No Drug Abuse. So here we're looking at screening and assessment, which can involve universal screening and psychological assessments, as we mentioned, but also more specific substance use screening tools. And when we're looking at universal screening, that's really intended to identify students with risk factors for substance use. Some examples of these universal screeners are the Strengths and Difficulties Questionnaire, the SDQ, which many of you might be familiar with, as well as the BASC, which is a longer assessment and not really a screener, but the BASC-3 Behavioral and Emotional Screening System, the BESS, that is a screener that's quite a bit shorter. And looking at substance use screening tools, these would be used to identify students at risk for an SUD and also assess the severity of substance use. Some examples are screening to brief intervention, and also the SBIRT for screening brief intervention, and referral to treatment, which is more of a system. Now, as many of you know, here in New Jersey, the state legislature really set the groundwork for comprehensive substance use prevention and intervention in schools, really ensuring that all children in every district have access to evidence-based prevention and supports. All New Jersey schools are required to have in place a comprehensive program of prevention, intervention, referral, and continuity of care. And the New Jersey Administrative Code that provides a good guideline for districts to establish these programs in line with the state requirements. Now, we don't have time to go into detail about the specific legal requirements, but I do want to highlight a few features. In line with evidence-based guidelines that we reviewed, prevention components are intended to reduce or eliminate incidence, prevalence, and risk factors, as well as increase knowledge, skills, and other protective factors among youth, as well as involve the school community. When looking at intervention and referral components, it really includes clear protocols for reporting, notification, examination of students, and that also involves community referrals for evaluation and treatment, as well as engaging students and parents in the process. The continuity of care component ensures that students in treatment receive continued educational programming and services, and also focuses on re-entry after treatment absences to ensure that that's smooth and that appropriate supports are provided, taking into consideration not only the academic needs of students, but as Maureen was mentioning too, the socio-emotional needs of students. In-service trainings are also another requirement, as many of you know, on substance use prevention and intervention. They're required for all staff and updated annually. And there are also requirements for parent and caregiver education programs. Annually, there are annual policy reviews, which involve both process evaluation and outcome evaluation components. And last, there's a program which provides for the employment of student assistance counselors in certain schools and districts. And these coordinators, rather, they ensure successful implementation of comprehensive substance use components in line with the legal requirements. So moving on to teaming, as with any component looking at suicide risk or substance use, teaming is essential in coordinating substance use prevention intervention programs. Really a key component of MTSS framework. Part of the teams that could be involved might include student assistant coordinators, INRS team members, child study team, also resiliency teams or school resource teams. And it's also important to consider parents, students, or community representatives who could also be included in these teams. And last, but certainly not least, cultural considerations are really crucial to efforts and success of any substance use prevention and intervention plans and programs. We know that cultural variables such as race, ethnicity, religiosity, sociodemographic factors, and sexual and gender orientations really play an important role in varying rates of substance use, risk and protective factors, stigma, and also treatment seeking. Culturally sensitive and appropriate school-based prevention programs have been found to increase engagement, not only among students, but also among staff in programs. And as we know from research too, engagement is really critical to positive program outcomes. When we consider culturally responsive programs, it's important to include universal screening and assessment and continual monitoring of fidelity and the intervention outcomes. These elements, they help us answer questions like, do we know the varying needs of our students, disparities that may not be readily apparent, sociodemographic and cultural factors that may be influencing risk and responsiveness to substance use programs. And we also have to look at our assessments. Are those culturally appropriate as well, the assessments that we're using? Ongoing professional development and training around substance use is also key in addressing cultural factors and potential disparities in access, delivery, and outcomes. And finally, the process of supporting our students' health and well-being with regard to substance use and beyond really requires the active and ongoing engagement of diverse community members that fully represent the students and the families who are being served. And here we have some additional reflection questions to consider on both suicide and substance use prevention in schools. And while we don't have time to go through all of these, again, these slides will be posted and made available to you. And now, without further ado, I'm going to turn things over to Superintendent Norsha with our school exemplar and the Maple Shade School District.
Thank you, Alicia. And I just want to say that I'm honored to be here to talk a little bit about our journey. I want to be clear that our journey doesn't mean it has to be your journey, and every journey is going to be a little different. And the journey gets hard and it gets challenging. But Maureen, I think, talked about it a little bit in her slides, is that one of the most important things is you have to talk to your students, and the students are going to kind of lead the way in this. So one of the things that to start out is it's okay not to be okay. And we're going to talk a little bit about where that comes from, teen mental health, and why that's a really good mantra to talk about with kids. It's okay not to be okay. So a little bit about us. We're a school district in Burlington County, which is located in southern New Jersey. We have about 2,300 students from pre-K on to 12th grade. And, we talk about mental health from pre-K on to 12th. It's not just limited to our high school students or our middle school students. It has to start younger, it has to start in the pre-K years and kind of building that foundation. We're a diverse population, which brings to us all students from all different backgrounds, all different lifestyles, all different areas of trauma that we don't even know about until they walk through our doors. And so talk to you a little bit about, how we got started and started on our journey. And we were probably where, like everybody else, right? We're just doing our jobs, we're educating students, we're looking out for their social and emotional well-being. And, we started in 2018 like everybody else. We started off seeing a lot of suicidal ideation, cutting and self-harm, and what did we do? And I know that both Maureen and Alicia talked about this. We followed school policy. We talked with our counselors. Alicia, you can advance the slide a little bit. We followed policy. We sent out to crisis. In a sense, we were putting Band-Aids on some probably really big issues. We did some triaging by our counselors. We talked with student groups. We did some out of darkness walks, but we weren't really making a huge impact. We noticed we needed to do more. So this is all pre-pandemic. So we also have to realize that where we were in 2018 and where we are in 2022 looks a lot different. But I think it's helpful to know kind of where we started and where we're ending up at this point. So the next part of our journey is we were approached by New Jersey Health Initiative, a product of Robert Wood Johnson Foundation, and they were doing a grant program, and they needed 3 school districts in the state of New Jersey, being Freehold and Cape May, and now Maple Shade was the 3rd. And we needed to find people to be trained to do 8 trainings over a 2-year period with their region. So this is the Youth Mental Health First Aid, and I will reference another program as well. And the Youth Mental Health First Aid is also, Maureen had referenced, is one of the programs that you can do to educate your staff and offer professional development. And it's true, it's an extensive training, it's 8 hours. One of the ways it's worked for a lot of school districts here is you break it up over 2 days. It has to be in a certain time period, but when you can plan for this as a school district and you know that you're offering 2 4-hour sessions, you're going to be able to plan a little bit better. So we were one of these districts. We were very fortunate that we were selected, and we had a lot of partners. The next slide, please. So what it consisted of is 5 trainers. We used 2 social workers, our nurse, a school counselor, and a police chaplain. So it's very important to involve your town. It's not just a school program. The more people that you have talking about mental health in your community, the better off you're going to be. We were fortunate to have a police chaplain as part of the police and the clergy in our town. So we also had the Mental Health First Aid USA and the Mental Health Association of New Jersey ran the training. So we had a lot of outside groups coming in to help us in our path. And you probably need that at first. You need the support as much as sometimes as school administrators or teachers, we feel we can and certainly know the talk and know how to help students. Without the true mental health professionals coming in to help us, we didn't even realize we were not always doing the correct thing. So we conducted 8 trainings, at least 2 per person over the course of 2 years. And all these trainers that you see in that picture is my 5, had to kind of go out and find their training. And it was kind of easy because when you want to talk about mental health, people want to help students. They want to be able to say, how can I help? I will help you. So we trained educational assistants in a lot of schools in Burlington County, all of in my school. We did teacher trainings, nurses from the county all came, parent groups, community members, school administrators. Anyone that wanted to have a training, we were going to send our staff there. And what is the benefit of a youth mental health first aid is that you have a lot of adults that know strategies, the language, the process, and the correct way to help. So a lot of people that know the language, and that's very helpful. So the next part of our journey, and that was in 2018, in the spring and summer of 2019, we were approached by John Hopkins, and they were interested in evaluating teen mental health first aid training. So it's different. So we had the youth mental health first aid, which was training adults, teen mental health first aid training students. So we were able to train 4 adults, 2 from Maple Shade High School, and they were 2 of my original trainers, and then 2 from the Mental Health Association that were working with my team. And they were trained in Orlando, Florida. Because it was another grant, we were able to get some funding, so the school district didn't have to pay this initial expense. So like I said, it's right now, if you're sitting at home, you're thinking that it's very hard to find partners, but it really isn't. You know, lots of times all you have to do is ask, and people will help, you know, when they know it's what's best for kids. So we held 8 student trainings with 4 trained instructors from the winter of 2019 and 2020. As you see from the pictures, we had a visit from Governor Murphy. This is when he announced his new initiative to support youth mental health first aid. And you see in one of the pictures that Governor Murphy actually spent time with the kids and listened to what they were talking about in class. This is a great experience for our students and for our staff. It was also to show the importance that New Jersey has in training people in mental health and how important it is. So during this year, and I will talk a little bit about what kids are, a little bit later, what kids are talking about when they talk about this training. But at this point now, we have our adults trained and we have some of our student population trained. But we also know kind of where we were in the 2020 and kind of what happened at that point in the pandemic. So we had just finished this in February, and the pandemic happened in March. It changed the landscape of schools and kind of some of our methods going forward. The next slide, please. So where we are now. So when we left, it was pre-pandemic. When we came back, we noticed students had a lot more difficulty than when we first began our journey. So what could we do? But now we have a lot of people that really deem mental health important, and it has to be first. If it's not first, learning can't take place. And our staff was realizing this. So some of the things that we are doing in our school year is we are now in our second pilot of Team Mental Health. We were able to get another grant, which pays for all your books. You do have to pay for, at times, your substitute coverage for your trainers, but it's well worth the time. We have a program called Care Solace. Care Solace connects students, staff, and their families to mental health care at no cost to families. There is a cost to the district, but it's very minimal when you think of what the services are. You know, Maureen talked a little bit before about a warm handoff. That is what the Care Solace program uses as well. So a warm handoff would be when one of our counselors connects the parent to Care Solace in a warm handoff to get some services they need. At this point in the year, we have about 70 warm handoffs and people that got the help that they needed. And Care Solace has helped them navigate that system, because we know families sometimes have a very hard time navigating a system in trying to find, you know, appropriate care. We are also a countywide stigma-free schools. We all passed the resolution that talked about that we are stigma-free. Burlington County, as commissioners of the county, they also passed a stigma-free county. So we're starting to do some countywide mental health activities. We're going to start in May, which is Mental Health Month. We have 2 programs, one middle school, one high school, and we are going to get one student from every school in the county together, and we have some activities planned for them. And some of it's going to be just a best practice share. We all know we're doing some things that are fantastic in our schools. What can we do now to get a lot of the fantastic programs in each of our schools? So we want to do some of that share, and some of that is just going to be talking to kids about, you know, what can we do? What help do you need? How can we better serve you? We've also have therapy dogs in our schools. We have one that is here every day in all 4 schools, comes and visits the different classrooms, different students. Sometimes it's built in systems of rewards. Then we've contacted agencies that come the first couple of days of school. So we have multiple dogs in multiple schools. They usually do this on a donation basis. So if you are thinking about what it would be great for your school to have therapy dogs, you just have to call around because people will come and help. And it's a great transition. We know for a lot of students in the beginning of school, it's filled with angst and anxiety. And it's really nice to have some dogs around because they're just happy and they make people smile. We also have some wellness activities we set up, especially in the younger schools. So not just geared to high schools, some yoga strategies, some breathing techniques, focusing on mindfulness, and calming techniques. We have literature and lessons. So we've selected literature at each grade level that focus on social emotional learning and inclusion, and as well as we develop lessons. So we have taken our lunch and learns at the high school, and we have kind of embedded in them some of your mindfulness activities. How can you de-stress through art? How can you de-stress through music? How you can use some of the breathing techniques found in yoga. You know, as adults, we all have found strategies that help us relax and calm, and we need to pass on those lessons to our students. We've contracted with counselor agencies. So in a time in New Jersey where we have received some extra funding in terms of helping kids transition back, we've used some of that to contract some agencies to help our counselors. Most school districts have 1 or 2 counselors in each school. High school may have more than that, but it's still not enough to support our children. So we've contacted with our counselor agency called Thrive. There's many different ones out there. They also will help with your parent nights and some of your staff training. So another thing that may cost some money, but it's, again, well worth it. We've last year and this year coming, we've developed targeted specific grades and students for summer programs. So we've looked at students that may be at risk, that may want to come in the summer. We offer a social emotional learning kind of camp that works on their social skills, that works on emotionals, different strategies of just, you know, mental health. And we do this for a couple weeks each summer. So just to touch real quickly on the main goals of Teen Mental Health First Aid, because I do think it's important when you have students helping students. And they just learn the skills that they need to help their friends. They do receive a manual. It is just like a course that you saw in the picture with Governor Murphy sitting with the students. They are taking a class. It does have them pull out of another class, but it's for only 8 sessions that they have to get pulled out, and we do rotate the schedule. And they just recognize some early warning signs that a friend is developing a mental health challenge, just like an adult would. However, we know that peers could see signs a lot sooner because they dialogue through text, they dialogue in email, where they see each other a lot more than adults may have conversations with them. And then the next slide, just again, would talk a little bit about the main goals, right? They do a lot of role playing in this class. It's not just a textbook and they're listening. They have to role play how they would talk to a friend about mental health. How would they get an adult involved? So very hands-on technique. So when we talk about some of the challenges and hurdles that we've experienced in this, it's always money in school districts, right? We never seem to have enough to do all the programs that we want to do. So you have to find partners. And we were funded through a grant to the Mental Health Association of New Jersey by the New Jersey Health Initiative. And then we were also Born This Way Foundation, which is the Lady Gaga Foundation. And they covered all the price and the training. So, some of that is you just have to go out and kind of like network and find people, and they will help with the cost. Time, right? Time in any of these programs. We had to pull students from different periods. They do miss some of their academic time, but we still stand behind the concept that kids are not okay. They're not at their potential. So we have to do what's best for them first, is address any of their mental health challenges. And time to put in all of these programs. But if you have a team together, everybody will use their strengths to find out what they can do to help the team and put in what program. And you have to have some buy-in, and that, as many of you in the classroom or in the schools will know at this point, is sometimes hard. Not every family or student believes in mental health education strategies or social emotional learning. There seems to be a lot of things out there in the public about SEL, and families are against it. But I think you just kind of have to keep chipping away at that and talking about that. We care about student safety at all times, and that's the most important thing. And just a few of this, you've got your successes and testimonials. These are what real kids in my school have said about the programs, right? They talk about that, I feel like I could have handled someone else's problems better if I learned how how to do better in the future. They talked about the course of stress, what we should be doing to help a friend. All this is very important. And there's some more. But I just want to, there's just some more testimonies, and you'll see it when you get the slideshow, and it's really helpful to talk about what kids talk about. But what did we learn through this stuff? We learned that even the smallest step makes a big difference. You've got to start somewhere. Start with therapy dogs. Start with having just kids talk about what they need, right? Starting with the small stuff. And I want to just say that, you can click on this link later, but it's Remember the Tale of the Starfish. And it's the story of the little girl or the little boy that was putting a starfish in the ocean, throwing them back in, and someone commented about why, there's millions of starfish. How can you expect to help all of them? And it made a difference to one. And that's how you have to start. You make a difference to one student, one at a time. And that the other lesson is people are willing to help. You just need to ask them. Find the partners, create your teams in your school, and people are willing to help. You just have to ask.
Thank you so much, Beth, for sharing the story of your district and so much of the wonderful programming that's going on. What a remarkable journey. And again, just to let everyone know, you do have access to the slides later on. So I didn't mean to cut off some of those beautiful testimonials, but feel free to return to those. And just to the next slide, here are some resources that were mentioned in our webinar today. You can access these resources. They're also available in the guide, and they'll be available with these slides. And I want to move now to some questions. You can include some questions in the Q&A, although in the interest of time, I think we might have had some that are already submitted.
Yeah, I can take that, Alicia. So yeah, thank you to all of our presenters. It looks like we have one question specifically directed at Beth, and I think it comes well off of your last point there of, people are willing to help, you just have to ask. And the question is, can you provide some examples of how you are able to get community and parental/caregiver buy-in as it relates to implementing your school mental health framework?
Sure. So one of the strategies we used was to hold, and remember we were kind of in the pandemic, but we held just virtual conversations just like this. We were able to talk about all the benefits of the program and what we're seeing. And I think the more open we were with parents, they understood that it was definitely needed in our schools. So it's just having that open communication, as well as platforms for parents to ask questions in case they did have questions that they were not sure of what we would be teaching their child.
Thank you so much. So all about having those open lines of communication and opportunities to kind of share. And we do have one question now for Maureen, and it's, what can schools do to support their school community after a student or staff has died by suicide?
So of course, I would suggest that you don't hesitate to call the Traumatic Loss Coalition, and we're out of Rutgers, because we can help support the administration and guide, but we could also, if needed, send out teams to support. And really, again, it's with the engagement, it's with the contact. It's listed in your resources too. I think the AFSP toolkit for after a suicide. The most important thing is really the connectedness and having the conversations and sending the message that it's okay not to be okay, and that we all have different feelings about this loss for our community, and no judgment, because what's really difficult when there's a loss, especially by suicide, is you might get messages from people like, we don't want to talk about it, we shouldn't talk about it, we can't talk about it. They need to talk about it. You need to create those safe spaces, and that's what we can help you do. But I can definitely send some additional resources of the guidance, and we train our responders on how to handle these situations without getting in the school's way. So I really encourage schools to reach out to us, because we'll guide, we'll stay in the background, we'll take whatever role you need the TLC to, and we'll guide you with best practices to keep it safe for everyone to have these conversations. That's really it. Letting students know that no judgment, we're here. If you see something, say something. This may be really difficult. We're in this together. And I think that's a lot what like Alicia and Beth were touching upon too, the connectedness, the resources, you're not alone.
Yeah, thank you so much. I love this theme of it's okay not to be okay. And I think this is something very important to remember and convey to our students and staffs.
Absolutely. Thanks so much, Maureen and Beth. And now I'm going to turn things over to Kati, who's going to tell us a little bit about the evaluation that we go through each webinar. That's very important. Thanks, everyone.
Thank you, Alicia. And thank you, Superintendent Norsha and Ms. Maureen Brogan for joining us today for our webinar and providing us with a wealth of information regarding this topic. As Alicia mentioned, we do have an evaluation component. In your screen, you will see a QR code, and you can use your mobile device to hover over it. Or if it's easier, you can also click on the link that will be shared in the chat box to our short evaluation survey. In addition to this survey, we do have a more extended survey that collects a little bit more of your opinions in depth, and that's optional as well. As we mentioned before, these surveys are linked to our funding. So, if you could please complete them, we really, really would appreciate it. And then on your screen, you will see a slide about our current podcast titled Toward Wellness and Recovery. And you can find that on Spotify, Apple Music, or Podbean. And it's our latest series, Flourishing at Work. And it's with Dr. Michelle Sekna and Dr. Tony Zippel. And they have a wonderful, wonderful podcast that we believe may be useful in keeping, up with your self-care and flourishing at work. Okay, thank you so much. And then on your screen, you will see also contact information regarding our, our social media handles on Facebook, Twitter, and LinkedIn, as well as our general email should you have any questions. You can also reach out to me. I will share my email in the chat box so that I can route your questions regarding this webinar or any other questions you might have regarding our center. Next slide, please. Okay, well, that concludes this webinar. We again wanted to thank you for joining us today. As mentioned in the chat box, all of our materials will be posted on our website within 7 days of this webinar, as well as certificates of completion will be sent out and a link to the recording and slides so that way you can share this information with your colleagues. Thank you again for joining us. Thank you to our presenters for providing us with this webinar, and we hope you enjoy the rest of your day. We hope that you stay safe and well. Thank you.